Dr. Pandav. Just a housekeeping thing. There is someone's pen drive lying here, as well as a hard disk, I think, which is with them that needs to be taken away. So someone has left their pen drive and their hard disk here. Okay, so I think putting in the tubes is easier, but managing the complications is much more tough. In fact, when I had started doing the tubes, my mentor told me that when 30% of them don't work, 30% of them will have complications, and it's only about 30% of the rest that actually work. So, and when we look at all the studies, it's nothing but true. There are complications. 30% will have complications. 30% will just fail, and you just would expect only 1/3 of them to work. So of those that we follow up over a period of time, and what we've seen from various studies is that almost the drop in visual acuity, which is significant, is about 30 to 35%. You have to keep that in mind, that they are going to have complications, and these complications would be visually threatening. So there is a problem, and that we have to deal with them. We have studied a large number of these eyes because we have a big setup of vitreoretinal surgeries being done, silicone oil being injected, silicone oil being removed, and then these eyes developing glaucoma. And when we studied their long-term outcomes with the Ahmed glaucoma that we normally use, we found that there were similar results. The eyes that were losing vision even after the glaucoma drainage devices was huge, and this was primarily because of the complications relating to the tube. So we have to understand that you have to deal with these complications, and if you are putting in a tube, you have to be prepared to manage these complications. And one of them is the tube endothelial touch. And the tube is going to touch the endothelium. If you're going to put it in the anterior chamber, there are going to be problems. And this was a gentleman in whom a surgeon had put the tubes both in the anterior chamber. He was a retired army officer, and his life was a hell after he lost one of the eyes because of corneal edema. He came to me with the other eye, and then I had to kind of remove this whole tube because, I mean, even if he's 60, 70, or 80 years old, he's going to live whatever he is going to live with that particular small vision that he's left with. So therefore, endothelial touch is something that is a potential problem, is going to happen. If it is a child, it's even more so severe that you have to deal with. So therefore, you must know that the tube has to be as away from the endothelium as possible. And one of the techniques to do this is to put the tube in the sulcus, as we were discussing. But short of that, you have to aim to put the tube at the plane of the iris, so that it's away from the cornea. The tube will also always continue to move, and there are articles that show that not only the tube moves longitudinally, but it can also move anteriorly and posteriorly. So even with the movement of the lid, you can see how much the tube can move and cause problems with the endothelium. So therefore, it's important that we deal with this complication even before it occurs. So we devised a technique where we tried to put the tube as way behind the cornea as possible, because when you're inserting the tube, you don't know where it will ultimately go. And to get that plane of the iris can become very difficult. So we devised this technique where you can hinge the tube at the limbus by placing another part of the tube under that tube, and when it is hinged, it will then go back posteriorly and lie on the plane of the iris. Now this is very important because you want an ideal placement of the tube, and this technique can help you do that. So I'll just show you a video of how we could do that. So the cut part of the tube we put the cut part of the tube, and we placed it under the tube that was going into the anterior chamber. So here you can see that a part of this tube here is underlying the tube which is over it. So therefore it acts as a hinge. It will cause a posterior movement of the tube, and it will help it to bend it away from the cornea. So this is one tip and which you could all take, and it might help it. If you don't want to use a tube, you can use an extra amount of sclera or the cornea that you have and place it under the tube so that you have positioned it as away from the cornea as possible. Right. Another problem that has happened and that I've seen happen is a touch of the tube with the lens, and this is also a potential problem because you have left the tube too long. And there are surgeons who have done this, but it's important that you go into the OR and at the first opportunity when you see that the tube is too long, you just cut it. Sometimes you don't know, on the table you have placed it very well, but 3 months down the line what's going to happen we don't know, in which case you may have to go back to the OR and trim the tube, and it's very easy to do that trimming. You can go with your vitrectomy instruments on both the sides and kind of cut the tube and remove the piece of that tube. There are some cases where you've put in the tube in the sulcus. You can see the tube in the initial postoperative period, but over a period of time you see that there is a contraction of the fibrous tissue which has led to the tube now lying under the iris. And this is a case of a missing tube and you just can't see the tube. There are possibilities that the IOP may be normal, but there are also possibilities that the IOP may be very high because the tube is blocking the iris is blocking the tube, or the vitreous is blocking the tube, in which case then you can do a UBM or an ASOCT probably to see the position of the tube and to gauge what is happening and then go ahead and do your surgery. So this was that same patient where the tube was lying behind the iris, and I could see that the tube is being blocked by the iris tissue on the UBM, so we had to reposition the tube. You may have to bring it from the posterior chamber into the anterior chamber so that it restarts to work, and it did. So this is another problem that you might face, and you have to be prepared to deal with it. You have to kind of put that tube back into the anterior chamber. Tube extrusion is another ghastly complication. I don't know how many of you have experienced it and how you've managed it, but I mean, I can frankly say that it is one situation which I dread, and I have had to remove most of these tubes and the plates because of the extrusion of the tube. But one of the techniques that we devised was, in cases of these erosions, was that we used the conjunctiva that was over the fibrous capsule that had formed over the plate, and we reflected that conjunctiva over the tube as a Momini's flap, you know, and sutured it, because most of these eyes, a lot of them were vitrectomized eyes with a very poor conjunctiva. We couldn't find conjunctiva from anywhere, in which case this was one technique, because if you try and use amniotic membranes, you try and use scleral patch, they tend to come off. So the best way to do is to use the patient's own tissue. With this kind of repair, you can get away maybe some days, but there are cases where even this tissue might retract, in which case we've also taken a part of the conjunctiva which was a free graft from the surface of the plate, which has extensive amount of tissue because of fibrosis, and kind of placed it over the tube and covered the tube. So we have had some success with this, but I can assure you that some of them just keep eroding again and again or retracting, in which case you may have to finally remove the tube. Another problem has been a cosmetic problem. Some patients have come out because, especially with the Barwell, because a huge plate and a large amount of capsule which is causing problems. In this case, it was placed in the temporal quadrant. The patient was young, he had a problem, he wanted the whole thing coming out. So there could be problems because over a period of time encapsulation happens and the whole thing becomes quite bad looking, and you may have to remove this plate. So understanding that when you are removing the whole tube, you have to do it in a meticulous manner, because when you are removing the tube, that area, the small hole that you have created, has to be sutured up meticulously. You have to cover it because the IOP might suddenly go down. There might be hypotony because of extensive leak from that area from which you have removed the tube. So you have to do that. You have to suture that area from which the tube has been removed, place extra tissue over that, and then of course you have to remove the entire plate or the tube in this particular case, Unfortunately, this patient also had a cataract because the tube was touching the lens, or probably because of the hypotony that had happened. And here I'm showing you how the patch is being placed over the area that had to be sutured, and then do a cataract surgery. In this case, it was primarily, the entire surgery was done for cosmetic purposes. So I'm going to summarize here by saying that you have to be aware of the complications. There are a large number of problems that you are going to deal with, and if you can properly insert them at the first place and manage them, you can get away having a very successful outcomes with most of these patients who have got refractory glaucomas. So thank you. Any questions? Yes. Yeah. So the first attempts are always given to close the erosion, to the eroded part of the tube. You must give an attempt to close it. So you put some tissue either from the plate or from any other part of the eye, maybe the inferior fornix, if you can get some conjunctiva free graft, and try to close it with that. There are cases where it might extrude, it may not stay there, in which case, I mean, you can give a few attempts to see how you can add doxycycline or, kind of stuff to prevent further erosions. But if it does happen and it recurs, then you may have to remove the entire plate and the tube. Yeah, I mean, you can cut the tube and kind of suture and let the plate be there. Of course, you can do that. Yeah, absolutely, absolutely. I agree. Even just leave the plate and yeah.
What do you do with the clear area?
We are a bit short of time. I think we have to
Yeah.
take that call.
With the raw area, when you reflect it, what do you do with all that raw thing above? When you reflect the conjunctiva and all that area
no, this
is raw.
is not raw. It has got conjunctiva. It's got a very thick Tenon's capsule under it. It's like an encapsulated plate.
No, agreed, but the conjunctiva is not there.
Yeah,
So
it
you just leave
heals.
it?
I've never seen anything actually happen. Yeah, I think we're short of time, but we'll take the question later. Thanks.
Can I have my slides, please?